My name's Richard Moody. I'm a family doctor in Fort St. John, and obviously this is Mary Augustine. Good afternoon to you all. So we had a great talk yesterday from Dr. Grundy, and one of the recurring themes I picked up on was that he felt that if we're going to look at integrated healthcare teams, looking at a new model for funding was really an important part of that. And up in Fort St. John, we've had the opportunity to pilot a program of alternative funding. And I've got to tell you that from a provider point of view, it's been a great success. It's been a very enjoyable way to work. And it's been very enjoyable for different doctors at different stages in their careers. It's been well accepted by the residents. This time last year we had an IMG join us, and he's been very happy with the way of working under the new system. And this year we've actually been able to recruit 3 of our 4 R2s that are graduating this year, and 3 out of 4 are staying in the community in a large part because of the funding model. It's been well accepted by those doctors in the middle part of their career as well. And in fact, one of our sort of one of the people that takes very slowly to change at a meeting, yeah, I'm being tactful there, at a meeting a couple of months ago said to my great surprise, says, if we go back to fee-for-service, I'm leaving the community. I had a chat to another one of them today because we're nearing the end of our sort of first year, and I said, how has this been for you financially? And he says, yeah, it's been pretty much revenue neutral. So he's very happy with that one too. And for me personally, it's made it a lot easier for me to look at slowly winding down as I approach retirement. It's given me the opportunity to start to work less without having to be faced with that huge monthly overhead, which I otherwise would have had to have deal with. So it certainly has been a great success for the provider. Just a little bit of brief history as to how we got there. Many of you may have heard of the real crisis, manpower crisis we had in Fort St. John about 3 years ago, and we did go to the residents and ask them, you know, what would entice you to work in our community, and we obviously got to remuneration, and they very strongly advocated for moving away from the fee-for-service model. And interestingly enough, of those residents that particular year, they all left the community and went to fee-for-service models. So anyway, we kept working at that, and certainly the current residents like it. The other thing that happened was that about that time, the government came out with some of their position papers on changing in rural health and integrated healthcare teams. And we thought as a community that we aligned very strongly with what they were talking about. We felt that we had a good, strong IT base, and that was a part of their position papers. We felt that we had a really good infrastructure because we were lucky enough to have purpose-built a new medical clinic, and we thought we had space to bring in some of these integrated healthcare professionals. And we were certainly open to discussions about a new system of payment. And so with great difficulty, we managed to get the deputy minister up to Fort St. John. And actually it was quite a contentious meeting, I thought, with Stephen Brown to begin with, because he got the impression we were asking for something. But when we got the message over to him that what we were asking for was to partnership with the government, because we felt we were in a good position to be a pilot model, once we got that kind of mutual understanding, we had a very productive meeting, and then we moved forward into the model, and that's how we got there a year ago. And we're just coming up to the end of the first year and now beginning to look at what happens next year. We've got a meeting later on this month to sort of review where we're going. And I'm going to ask Mary to talk about the model because she really is the expert in it.
I mean, the question we get asked all the time is, how does the payment flow? What is the financial aspect of the model? So there's really 4 basic streams to the blended population-based funding model. And the first is the patient population. So there is a base amount of funding based on, I know you don't like the word panel, where's Rebecca? But each physician has their own patient panel, but it is based on a practice model. And the second part is the complexity, and that's where it really is important for anybody that's looking at moving into a new model to really ensure, that you know who your patient panel is, and really working on the foundational piece with your EMRs, because the complexity piece is based on the problem list or the health issues in your EMR. The third part is around screening. So there's some quality improvement measures around screening. So there's 10 indicators, 5 of which were selected by the ministry and 5 that were selected by family docs. And those are things like your blood pressure, PAPs, mammography, colorectal screening, etc. And then the fourth part that makes up the payment part is your fee for service. So there are your typical in the basket items, which are through the population-based funding. But there is also some of those procedures that Rebecca alluded to earlier that just happen in practice. And those are fee-for-service elements, as well as your work in the ER, OR assist, anesthetics, and in our community, prenatal care, because that's provided through a prenatal clinic by all physicians in the community. So that's considered out of the basket. So I don't know if there's anything else you wanted to add to that part.
Yeah, the other things that are out of the basket would be WorkSafe BC, ICBC, any medicals that you may do, driver's medicals. So there is a significant amount of money that is still fee-for-service based. So, Mary, do you want to talk about any of the challenges?
Sure. Our biggest challenge actually has been around what we thought would be the simplest part of the model, which is actually who is your panel or who are your registered patients in the population-based funding. And why that's so important is because the other really big element of ensuring the success of the model to some degree is around outflow, because that was some of the mistakes that were misjudged in Ontario. But the outflow could be directly tied to your paneling process. So what we thought we were moving away from was this whole complicated incentive billing system, but instead we moved into quite a complicated paneling and registering system, which we're hoping as the prototype moves into something more sustainable, that will have a system that actually can provide the real-time data around the criteria for paneling, because it has a lot to do with your LHA that you live in. Like, for an example, our catchment area is LHA 60, so any addresses that would fall outside of that, you would not want to register because of the potential for outflows. It gets a little bit complicated.
Does everybody understand the concept of outflows, why there are outflows, or would you like some explanation about that? Yeah. It goes to the Ontario model that the family physicians were given a global sum, but the government found that they weren't necessarily providing all of the services that they should have been providing. Out-of-hours service, patients going to seek health care from other physicians in the community, and then billing the Ontario health plan, whatever it is. So those are the outflows, people who are getting service that you have actually been paid to provide. And that's what's been built into this system. And discussing those outflows is incredibly complex. For example, as we discussed it, to me it's an acceptable outflow for people to go to emergency departments, because that's the way we work in rural communities. But it still comes as an outflow to me. And CTAS 4 and 5, which they use for their measure of outflows, I mean, CTAS is all about triage and patient flow. It's not about economics. And if I'm getting an outflow penalized because a 3-year-old child is turning up in the emergency department because they've got a laceration in the foot. I've got a bit of a problem with that because I certainly don't want to be stitching up 3-year-old kids in my office. I don't think that's the appropriate place for it. So outflows is really quite a challenge. Using CTAS for outflows is a challenge. Patients who are getting other services in the community. Well, you know, my office is open and we see an awful lot of, or we have an awful lot of same-day appointments. And I don't have any control over people that phone Medio for a consultation, but that's an outflow. You know, none of us understand why patients will choose to go to the emergency department at 2 o'clock in the afternoon when they could actually be seen in their family's doctor's office. But that's patient behavior, things that we don't always understand or have a control over. So outflows is a continuing discussion.
But the good news is that it has, you know, prompted us to look at, you know, access in general as an issue. I mean, just for an example, an average day in the Family Practice Associates, there will be 67 same-day appointments open now between the 7 physicians in that office, as well as a same-day access clinic that's open to all of the patients of that clinic. So it has kind of made us look at some of those other things as well, look to improve things like access.
But having identified those challenges, I'd still like to go back to where we started from. From a provider point of view, it's very successful. It's a great way to work. I think it merges well with working in an integrated healthcare team and delegating those tasks that we don't need to get involved in, and then wondering how you're actually going to get funded for that. Is this sustainable? It comes back to all of the questions we have about pilot projects. What happens when they end? I guess we'll have to see what's happening there. And, you know, is our model going to be the final model? Probably not. I'm sure there are going to be lots of changes. But I think it is, from my point of view, nice to see a move away from the fee-for-service model. Thank you.